Good afternoon, my dear colleague. It's my great pleasure to have an opening remark for this industrial symposium. As you know, high-food technique was done in Taiwan in 2009. It's quite early. But since 2021, Sonablate was introduced in Taiwan. I think more and more high-food procedure will change to be Sonablate technique. That's why we have this industrial symposium. We will discuss why we change from ETAP to Sonablate. What's the advantage? And we can exchange our knowledge and maybe promote our technique. So I want to introduce the second opening remark speaker, Professor Shoji. He will present his opening remark. Welcome, Shoji.
So thank you very much, great opportunity. So my name is now Shoji. So I would like to introduce this session. So now standard management of practice for localized prostate cancer, active surveillance and radical treatment. By the development of the imaging and the treatment modality, possibility of the focal therapy for localized prostate cancer has come to be noticed. So could I ask for a show of hand? Please select the treatment as you are patient. There is no correct answers, please, okay? So first, 64 years old, PSA level was 10.2, and he has no past history. MRI transfusion image guided biopsy and 12 cohorts systematic biopsy were performed. Finally, we diagnosed the patient as having a clinically T2C and 0M0 in the apex area, Gleason score of 3+4, and right side of the prostate, Gleason score 3+4. Please raise a hand. So radical prostatectomy without nerve sparing. Okay, so if you are patient, which treatment would be selected? Please select. So radical prostatectomy with left nerve sparing. Oh. So radiation therapy. So focal therapy. Oh, you are very strongly focal therapist. So, but this patient selected radical prostatectomy without nerve sparing. This is one of the treatment option for the patient, not correction, not correct answer. So next patient, 40 years old, PSA value was 4.2. So MR fusion biopsy and 12 cohorts biopsy were performed. So finally, he was diagnosed as having a prostate cancer in left side with Gleason score of 3+4. What the treatment option were selected? Please select. The radical prostatectomy without nerve sparing. Radical prostatectomy with light nerve sparing, radical radiation therapy, and focal therapy. Okay. So he selected focal therapy, focal ablation. So last case, so 78 years old, PSA level was 9.2. So he had bilateral osteoarthritis, glaucoma. So because of this disease, so he has not ability to visit the hospital. So he has very small prostate cancer in left side peripheral zone, Gleason score of 4+3. So radical prostatectomy without nerve sparing. Radical prostatectomy with light nerve sparing. So radical therapy, focal therapy. Okay, so you are very strong, very good. So he selected the focal therapy, left hemiablation. The patient presented now have all shown no PSA elaboration for the over 5 years. So because each patient's circumstances are unique, focal therapy would potentially have a role in select patient. So high-intensity focused ultrasound produces ultrasound waves generated by a spherical transducer delivering ultrasonic energy to pinpoint 4 millimeter in diameter. The thermal and mechanical effect of HIFU destroy targeted prostatic tissue. The distinct margin between the treated and adjacent untreated area is observed in the prostate treated with HIFU. These characteristics make HIFU an attractive therapeutic modality for focal therapy of the prostate to cure while preserving continence and erectile function. So I would like to show you the adoption status of HIFU in Asia. In Taiwan, Japan, Hong Kong, mainland China, and in Malaysia. So many institutions have introduced HIFU treatment for the localized prostate cancer. So focal therapy has the potential to expand rapidly, requiring the acquisition of both knowledge and technical skills. So today, we are honored to have expert speakers. Please enjoy the session. Thank you very much.
Good afternoon, everyone. I'm Dr. Huang from Taipei Veterans General Hospital. The first topic we're going to speak is about the local treatment for prostate cancer. That's a lecture by Dr. Chen. So I will briefly introduce Dr. Chen. He's our young staff in our hospital, and he has some experiences about the treat prostate cancer with every kind of treatment for that modality, including HIFU and robotic surgeries. So today he will give us an introduction about the updates of localized prostate cancer treatment.
Yes. So now my topic is update of localized prostate cancer therapy. So conventional management of localized prostate therapy, we should consider patients' tumor risk stratification and life expectancy. And previous conventional therapeutic options includes watchful waiting, active surveillance, radical prostatectomy, and radiotherapy. And nowadays, with advances of technology, focal therapy become an alternative choice for localized prostate cancer. So this is the advances of focal therapy, which is published in Journal of Urology in 2023. The focal therapy began in 19th centuries, and we have HIFU, have cryoablation, photodynamic therapy, and so on. Meanwhile, we also have IRE, which is irreversible electroporation, and we also have microwave ablation. So let's look the guideline. The guideline says, NCCN guideline says focal therapy. NCCN guideline only puts focal therapy in post-radiation settings. This kind of focal therapy includes cryotherapy and HIFU. This is the EAU guideline. EAU guideline only suggests that if patient have intermediate risk disease, we only offer Wogan ablation or focal ablation within clinical trial or registries. In 2024, the focal therapy has the BJUI published a consensus regarding the focal therapy. Regarding the histopathology, the consensus suggests that focal therapy should not be offered to patients with localized ICUP prostate cancer if they agree to active surveillance. Focal therapy should be offered to patients with localized ISUP2 prostate cancer, even if they agree active surveillance. And patients with ISUP2 and ISUP3 prostate cancer, we also should offer focal therapy to the patient. However, if the patient's ISUP is greater than 3, we should not offer patient focal therapy. Regarding the MRI and biopsy finding, focal therapy should be offered in cases of extracapsular extension on MRI, and focal therapy should not be offered in cases of negative MRI and positive biopsy. However, if the presence of positive biopsy outside the lesion detected on MRI do not contraindicate focal therapy. So the role of focal therapy for localized prostate cancer. Focal therapy presents a middle ground option between active surveillance and radical treatment for localized prostate cancer. The primary aim of focal therapy is to manage the disease effectively while concurrently safeguarding the patient's overall quality of life. So now I'm give a short introduction of common focal therapies. The first one is HIFU, is today's main topic. HIFU is used focused ultrasound to heat tissue to 70 to 80 degrees of Celsius, and causing thermal coagulation, necrosis, and cavitation. However, the main problem of HIFU is ultrasound may attenuate. The ultrasound may lose of sound intensity as it passes through tissues. So previous studies show that prostate cancer located in the anterior part of the prostate gland have a 2 to 3-fold higher risk of treatment failure after HIFU. Another common focal therapy is photodynamic therapy. Photodynamic therapy is to administrate a photosensitizer to intravenously or orally. The photosensitizer will accumulate in tumor tissue. Then we may insert transperineally or transrectally insert optical fiber. The fiber will deliver specific wavelength light and to generate the ROS to make tumor necrosis. This is photodynamic therapy. Now the third, another common focal therapy is cryotherapy. Cryotherapy is to insert cryoprobes to deliver extremely low temperature around -40 degrees Celsius direct into tumor tissue, causing irreversible cellular damage. And common usage gas is argon for rapid freezing and helium for rapid thawing. Cryotherapy, because cryotherapy technology advances, thermocouple monitoring for cryotherapy is to ensure complete tumor ablation while preserving critical structures. And advances in smaller diameter cryoprobe allow more precise targeting and reduce bleeding-related complications. Now move to the IRE. IRE is irreversible electroporation. To place the needle electrodes are inserted around the tumor via transperineal approach, and the probe will generate high voltage pulses and causing cell membrane disruption between two probes, causing tumor cell apoptosis. So IRE has the advantage of sparing surrounding functional structures, such as blood vessels and connective tissue. The last one is targeting microwave ablation. Microwave ablation is to insert a probe into the tumor region, and the probe emits microwave, causing water molecule in the tissue to oscillate rapidly and generate heat. TMA uses thermal destruction of tumor cells. In our hospital, we also established the Heavy Ion Therapeutic Center, which use carbon ion radiotherapy, CIRT. This is more similar to the conventional radiotherapy, but using CIRT. CIRT had better dose distribution to protect normal organ. This called Bragg peak, just like proton. So CIRT had higher relative biologic effectiveness to kill cancer cells. So this we treat about 122 prostate cancer patients since 2023. Finally, I think current technology do not completely ablate prostate tissue. Based on previous study, the infield recurrence of HIFU is about 10 to 37%, And the infield recurrence of prior ablation was about 2 to 40%, and for IRE is 16 to 23%. So in conclusion, management of localized prostate cancer should be guided by the level 1 clinical evidence. Focal therapy bridge the gap between active surveillance and radical treatment in managing localized prostate cancer, balancing functional and oncological outcome. However, this need thoughtful patient selection. Last, current technology do not completely ablate prostate tissue. This is my presentation. Thank you.
Thank you, Dr. Chen, for the brief and condensed review of all the updates. I think time is limited, so I will hand my microphone to next moderator, Professor Tay. Thanks so much.
All right. Good afternoon. Next, we're going to invite Dr. Vincent Kaur to the podium. Dr. Vincent Kaur is a urologist at the University Putra, Malaysia, teaching hospital. I've had the pleasure of knowing him for many years, and he's also very interested in focal therapy, a very keen focal therapist who has embarked on several different focal therapies. So today he's going to tell us about who is not the patient for focal therapy. Vincent, please.
Thank you, Mr. Tay. Good afternoon, everyone. Thank you for the organizer for inviting me to give a talk on, and it's my pleasure to speak in front of several giants and pioneers in focal therapy. So I'm Vincent from Malaysia. So this is my disclosure. I do microwave ablations, HIFU using Sonablate and Focal One, and we're probably starting a 909 next month. So I think Dr. Chen has actually paved a very good foundation in introducing the role of focal therapy in intermediate risk prostate cancers patients. So these are the weapons that we have for localized prostate cancer. Standard of care, we have our robotic assisted radical prostatectomy and radiotherapy. But sometimes you wonder if you have this kind of lesions, very small lesions on the peripheral zone. Systematic biopsy was negative, and you wonder whether these treatments actually overkill the patients. So that's why I think focal ablations therapy comes in a very good, it comes in the right time and the right place to treat these kind of patients. So radical prostate and radiotherapy is still the gold standards for high-risk disease, but the intermediate and low risk, especially those with unifocal lesion, should they risk themselves to have incontinence and erectile dysfunctions. So as we know through our days, not all low risks are actually suitable for active surveillance. There's a risk of undertreatment, and not all intermediate risks should go for radical treatments, and there's always risk of overtreatment in this group of patients. So unlike the traditional whole gland approach like the surgery and radiotherapy, focal therapy targets only the dominant index lesion within the prostate, and the area that is most likely to drive the progressions of disease and metastasis, and sparing the remainder of the glands and the surrounding structure, and preserve the quality of life of the patients. So as we can see from this, the focal therapy comes in a very nice sweet spots in between low and intermediate risk prostate cancer with localized disease, and that could probably be the answer of over treatment of prostate cancer that we have been facing for so many years. And patients really want these options, and the evidence are actually evolving very rapidly. So as for now, in 2025, there are many RCT that is ongoing that's comparing focal therapies and radical treatments, especially in intermediate risk patients. And in the EAU, as we can see, the recommendation now is strong that we should actually offer patients with intermediate risk the focal therapy options. So now, focal therapy promise cancer control with less side effect, but who shouldn't get it? Like, these are two of my patients. Two different patients on the left side have one lesions on the peripheral zone, and the other one has very obvious semi-nervous-cycle invasions. Both had a PSA of less than 20, Gleason 3+4, intermediate risk, but should we give focal therapy to these patients? So we explore and see how we're going to select our patients. So I like to divide my patients' selection into a few several factors. First of all, the patient factors. The life expectancy should be more than 10 years. Ideally, they shouldn't have any previous radiotherapy or to the prostate or pelvis. And the patient's desire to preserve his erectile functions and continence functions. And as for the disease factors, ideally, the PSA should be less than 15. Those with 15 to 20, we must always counsel with cautious. And localized disease, preferably unilateral disease, although bilateral ablations is always possible with a different energy modality. Patients should be within the intermediate risk prostate cancer with either grade group 2 or grade group 3 cancer. And the cancer focus should be less than the tumor volume should be less than 1.5 mils on MRI. And sometimes you can go up to 3 mils if you consider to do Hemming gland ablations. And in the histology, there shouldn't be any adverse features such as intraductal carcinomas or cribriform pattern. And of course, the most important factor is also what kind of facilities you have in your centers, and also depends on the anatomical factors, whether the lesion is in the anterior or lesion in the posterior. So I like to, for beginner, we would always like to tell the anterior lesions are usually more suitable for needle-based treatment, and the posterior lesions are for the transrectal HIFU. So these are the few energy modality that we have currently: cryotherapies, HIFU, IREs, and also microwave. And before we do a focal therapy, these are the few important workup that we usually do for the patients. We do an MPMRI prostate to localize the lesions, to assess the volume of the tumor, and also to rule out any evidence of extracapsular extensions and also seminal-vesical invasions. And we should do a good mapping biopsy to actually confirm the disease laterality and also to rule out any contralateral clinically significant disease. And PET scan actually can also help. Although the evidence is not very strong, you don't really have to do it in all cases, but if you have the facilities and the patient can afford, it actually offers some added sensitivity in terms of patient selections, especially in a scenario where your MRI is equivocal and your PSA kinetics are a bit atypicals. And lastly, genomic classifiers using tissue tests like Decipher test or Polaris test will somehow support decision making, but it's actually not yet the standard of care. So selection is not about who deserves focal therapy, but actually who will actually benefits from the treatments. So the question is not who to treat, but who we must choose with cautious. So mainly looking at the disease factor and system factors. Okay, so I just wanted to share some of the failure case that I have throughout my few short journeys of focal therapy. So these are the 62-year-old Malay gentlemen, pensioners, ECOG 0, has only hypertension and dyslipidemia. Incidentally found that the PSA elevations were 8, DRE was benign, still sexually active, has a wife which is younger than me, and MPMRI prostates actually show there's a solitary lesions, Pyrex 5 lesions at the right apex with a bit of capsular breach posteriorly. And he did a targeted biopsy in a private hospital, which was not done by me. And the biopsy showed that there's a Gleason 3+3 cancer on the target. And also mainly the cancer is on the right side. So that patient was actually put on active surveillance by the private surgeons. And somehow the PSA raised up to 10.11 on 2024 and repeated the MRI. Showed that this is the lesions here, which you can see there's a bit of blurry areas at the capsule. And we repeated the biopsy again, it was 3+3. I mean, the private surgeon repeated the biopsy again, it was 3+3. So he was referred to me and was counseled for HIFU ablations. So we did, because of his sexual functions and because he has a very young wife, so actually, we counseled him for radical prostatectomies because of this capsular breach. We say that this is probably not the best case for HIFU, but he insisted that he wanted to try. So I actually did a HIFU quadrant, the HIFU ablations, and PSA from 10.57 dropped down to only 4.75 in 3 months. It's only about 55% reduction, which is not the best for focal therapy. And after 9 months, it came up to 8.94, and the repeated MRI showed that there's residual disease and enhancing residual disease. So actually these patients are still not decided whether he wants to go for repeat ablations or surgery, but we have strongly counseled him for repeat surgery. So this patient had a fairly good life expectancy, very healthy, solitary lesions, low risk based on the Gleason scoring and the PSA. But on the MRI, it shows that there's locally advanced features, there's capsular breach. And most importantly, the biopsy was not really done by me. So, I mean, if you're going to do a focal therapy, the most importantly, you really should do your biopsy yourself to actually map the cancer nicely and to rule out any other problems. So these are the lessons that I learned from this case. And second case, a 75 years old Chinese gentleman, ECOG 1, had a stable ischemic heart disease, centered on cardioprints, and he had incidental findings of a PSA of 7.7 and subsequently raised up to 9.93. And we did an MRI prostate, showed that there is a very small prostate, but anteriorly there's a big lesions, about 1.4 cm if you look from here, 1.5, but actually it's quite long. It's about 2.6 centimeters. And there's another Pirates 4 lesion on the left side, which turns out to be negative. And PET scan actually showed there's a negative for metastasis. So we did a biopsy, and only this area, as you can see the red one, only this area has cancer, 4+3. And then there's some systematic biopsy which turns out to be a grade group 1. So these patients, we actually did a targeted microwave ablations for him because at the point of time, we don't have any other needle-based treatment options. PSA of 9.93 actually drops only very little to 6.64 in 3 months, only about 33% reductions. And subsequently, it's still about 5.84. And the repeated MRIs on 6 months after the ablation show that there's still some residual disease. So in this case, life expectancy is good, solitary lesions, intermediate risk, but the tumor volume is actually too big. Retrospectively, when I look back, tumor volume is too big. And although the PSA actually is low, but the PSA density actually is quite high. So that makes me wonder whether the PSA density actually plays a role in terms of selecting our patients. So I found out this one retrospective studies that show that actually in the multivariable analysis, they show that PSA density actually is one of the important predictors for treatment failures in patient who has underwent cryotherapy in this center. So case 3, 69 years old, active surveillance for prostate cancer since 2022, and subsequently the PSA came up to 12, and then subsequently repeated MRI showed that the same lesion, but the Pirates 4 apex is positive, and one of these Pirates 4 right apex is positive. Looks fairly small on MRI. Looks like a very good candidate for a focal therapy. So we did a biopsy. These are the area where there's a 4+3 cancer, and the rest actually only have grade group 1 cancer. So this is the index lesion. And we did a PET scan, and it didn't come to my mind. The SUV max were actually quite high. It's quite bright actually. So this guy actually went through a targeted microwave ablations, and PSA from 7.43 only drops down to 5.98 in 3 months. Very little, 19.5% reductions. This guy haven't had a repeat MRI yet, going to have soon, but as you can see from here, intermediate risk, visible index lesion, life expectancy, but I find that there's non-concordance between the MRI lesion and the PET scan findings, and somehow I wonder whether the high SUV max actually probably suggests probably the patient had a higher grade of disease, or maybe maybe it was a surgeon factor where I didn't really use the energy appropriately. Probably I should use HIFU for these posterior lesions. I'm not sure. So these are some of my failure case. And lastly, I will just do a summary, and thanks to this is a table courtesy to my mentor, Professor Peter Chiu. These are the treatment modality that's available in our market at the moment, and these are the selections. These are the disease factor that is suitable for each modality. So focal therapy is not for everyone. So poor selections results in under treatments, And we must still remember the gold standard remains prostatectomies and radiotherapy for high-risk cases. The ideal focal therapy candidate is rare, but so selecting out is as important as selecting in. So focal therapy can only succeed not by treating more patients, but by treating the right patients. So this is the mnemonics that I developed. So no focal for this group of patients, non-localized disease. We cannot see the lesions from MRI, then it's not really a candidate. If it's multifocal disease, if its volume is very big, close to critical structures, if there's an adverse pathology like intraductal carcinoma or cribriform patterns, or if the patient has very low life expectancy or is very likely to defaulted your follow-up, then these are not the patients for focal therapy. So lastly, I would like to thank my mentors who had helped me a lot in my focal therapy learning, Mr. Siva, Professor Peter Chiu, and Professor Tay. And thank you very much.
That's a great talk, Vincent. Any questions from the floor? I think we might only have time for one question. Yeah.
Thank you for your excellent speech. And I have one question: is that there are growing body of evidence that indicating that MRI invisible lesions tend to have more favorable genomic profiles and clinical outcomes. However, on the other hand, several studies using novel imaging to guide focal therapy have found that, in addition to MRI, PSMA has significantly enhanced lesion detection and helps exclude patients who are not suitable candidates for focal therapy, reducing the risk of undertreatment. I would like to know whether your thought is believed that MRI invisible lesions should be approached with greater caution, or whether, given the increasing correlation between imaging finding and the genomic data, it is reasonable to defer treatment until such lesions become clinically significant.
Okay, thank you very much. So I think now there are a few studies that actually look into MRI visible lesions and MRI invisible lesions, and they have actually found that MRI visible 3+3 actually behave like a 3+4 disease, and MRI invisible 3+4 has a better prognosis compared to a visible 3+4. So I think the visibility on MRI actually is very important. And nowadays, I actually encourage my patient to do a PET PSMA for treatment selection and planning. And I have a few cases where actually it's not visible on MRI, and biopsy, especially the biopsy was not done by me. I usually do a PET PSMA, and turned out that I'm not very sure. Some of the patients actually their PET PSMA is positive, but biopsy is negative. But I find that when you do a PET PSMA, if your PSMA uptake is quite symmetrical, there tends to be negative. If you have a unifocal, very intense uptake, there tends to be positive. So this is how I approach. Yeah. Maybe Professor Tay, you have any comments on that?
Yeah, well, I think that in my mind, I think PET always gives more information. I think there have been some studies out there which MRI missed the lesion, PET picked it up. Then there are some that PET missed, but MRI picked up. I think the delta is somewhere on the order of 5%. Yeah, so it's not a large delta. But having said that, PET scan is going to add cost for the patient. So I'm into selecting patients as well. But all those measures they listed there, they do an MRI, do a biopsy, maybe they do a PET scan. One day they'll do genomics. That would escalate the cost of focal therapy a lot. So that's something that we keep in mind for patients as well. Yeah.
Bulbul from Lebanon. I agree with you that you need to do the biopsy, or at least know exactly who did it. Nowadays, we're doing perilegional biopsies. We use IRE in our center, and it's really important to know the extent of the disease. My question to you, do you routinely biopsy patients and follow up like a year down the line, or you just do for-cause biopsy?
You mean the repeat biopsy after the focal ablations? Yeah, routinely we do a repeat biopsy after 1 year. And we still do a systematic biopsy as well to make sure there's no outfield recurrence.
In-field, out-of-field.
Both infield and outfield.
Okay, I think that's our last question.
Thank you for your speech. I want to ask, what is your ideal PSA reduction after focal treatment?
Okay, I think the UK has one a very good study that shown that actually more than 70 or 80% reductions after focal therapy is associated with better outcome. So usually I tell patients if they are repeat PSA in 3 to 6 months after ablation, if there's about 80% reduction, I would say these are actually considered success. But there's a very good data from, I think from UK, they did a very good study from Clement, I think Mr. Clement from UCLH.
Okay, thanks so much. I think in the interest of time, I'm going to
Thank you very
invite
much.
the moderator for the next session up, Professor Kwan Cho Chen.
Okay, it's my great honor to be invited to UAA Congress to introduce the next speaker, Dr. Peter Chu. We think that Dr. Peter Chu is our good friend of Taiwan urologist. And now he is the president of the Hong Kong Urology Association. He also is the several international journals editorial boards, including British Journal of Urology, European Urology, and the International Journal of Urology. And today he give us a talk about the oncological and the functional outcome of focal therapy. Please.
Okay, thank you very much. So I'm. I actually get to know that I need to give this talk from another company telling me that, hey, you're going to talk that time. I said, I have never, no one actually told me that. Okay, so I'm here. So yeah, so I'm in the next 9.5 minutes, I will talk about oncological and functional outcomes of focal therapy. So some disclosures first. I've absolutely no honorarium for this talk. But I did get like travel supports and honorarium from various different companies. And Coelis actually supports the clinical trials that I've been working on, the microwave in the various clinical trials. I do robotic surgery and various focal therapies. So hopefully I will give you a slightly less biased, but at the same time, I'm not going to compare the energies. I'm going to tell, in general, like looking at focal therapy, the outcomes of it. So most of the papers that I quote in the coming 9 minutes would be for partial gland ablation. Okay, so we know that for the energy ablations of the prostate, it started off like whole gland HIFU, whole gland cryo. But in the recent years, as we have more better imaging, like with MRI, and now we're emerging with the PET scan too, then we are having more precision in diagnosis. And also whole gland treatment actually gives us not only longer operative time, longer Foley time, more urethral toxicities, more erectile dysfunction, and probably more difficult salvage prostatectomy if needed in the future. So about the oncological outcomes, mainly it's divided into the rate of biochemical recurrence of the treatment and also the retreatment rate. The retreatment rate can be the need of a repeat focal ablation versus a radical treatment. So I have been quoting this paper for a few years. This is actually quite, it's published like 6 years ago in BGUI, and actually a nice cohort of a focal or hemigland HIFU for localized prostate cancer. And here, I think an important message is, one is that like a lot of patients, if you follow up them long enough, like up to 8 years or so, 40-something%, around between 30 and 50% eventually may need some retreatment. But however, most of them can actually be retreated with ablation. Some of them needed radical treatment. So the radical treatment-free survival at 5 years is around 90%. At 8 years is around 80%. So 80% radical treatment-free at 8 years is a pretty good percentage for me, and actually for most patients. Another paper published, I think Professor Emberton is actually one of the senior authors here, by Reddy Deepika, looking at the failure-free survival rate. The failure-free survival, FFS, was defined as the whole gland salvage treatment, the third focal treatment. So the second focal treatment is not defined as a failure. The third focal treatment was part of the failure. Any systemic treatment, metastasis, or prostate cancer-related death. So, sorry for the big table. I only want you to look at the failure for survival. For example, at 5 years is 82%. 7 years is like 69%. But when we look at the whole gland, salvage, whole gland or systemic treatment-free survival, 5 years is 85% and 7 years is 75%. So it's still 75%, 80%. It's pretty good. Also, it very well depends on what is the patients that you include, of course. There is a non-randomized comparison using a propensity score matching between the HIFU or cryo done in the UK series versus radical prostatectomy. Mainly, I believe, should be in intermediate risk disease patients. And interestingly, the failure-free survival between surgery and focal therapy is actually very similar at 5 years and 8 years. Now, this is non-randomized, so there is, of course, a selection bias in that. So how would ablation, partial ablation, be having a better cancer control than taking away the whole gland? So but I think the message here is that it is not inferior to radical prostatectomy in well-selected patients. And recent year, I really love to share this slide because this is really excellent data from Professor Sonablate. At a median follow-up of 4 years, between low risk, intermediate risk, and some high-risk disease, doing partial gland HIFU ablation, the biochemical recurrence-free survival I think at 8 years, it's still more than 80%, even for high risk. So this gives us a strong message that it's not only about the energy, it's also about the experience. Whether you know how to use your energy well. And the radical treatment-free survival for intermediate risk is 95%, for high risk is 95%. So look at that. It's better than a multi-center cohort, but of course it is kind of a single center data in a kind of an expert center data. So it's slightly different. Don't offer this to your patient when you are doing HIFU, because you probably cannot achieve that. But also, besides experience, I think care selection is also very, very important. We also look at other focal therapies like focal cryo. The biochemical free survival is like 70, 90% between, but this is of course a variable follow-up time. The longer the follow-up, the more recurrence you get. And I'd like to quote my good friend, Dr. Chen Chung-Sin from Taiwan. They've been doing more than, I think, 500 cryos. Most of them are actually whole gland cryo. And this cohort is a high-risk disease, whole gland cryo, and look at the median follow-up is 10 years. 10 years. How often do you get median follow-up of 10 years in focal therapy? Of course, for high-risk disease, the recurrence would expect it to be high. So at 10 years is around more than above 50%. So it's not too bad. Instead of 10 years, 50%, recurrence that you need to retreat with this radical treatment. But they also look at how many high-risk features in the year the classification that if you only have one high-risk feature, actually it's not too bad. You just have like some 4+4, or it's just because your PSA is 22, it doesn't make it a really, really high-risk disease. So IRE, my friend Zhang Kai from Beijing wrote a systematic review on IRE nanoknife for focal treatment for prostate cancer. The 3-year failure-free survival is actually 90, 91, and 96% in the 3 studies, but that's 3 years. But the infield significant cancer recurrence rate that I want to point out is 0 to 33%. So there's still quite a wide range of local recurrence, infield recurrence, which shows that, the case selection, or probably how you use the IRE, is actually also very important. This is the targeted microwave ablation trials that have been doing in this very small trial of just 30 patients, 42 lesions, the infield recurrence, positive biopsy rate was, 90.5%. There's no cancer in the treated area. So I just want to stress that just now Dr. Vincent Kaur showed two very bad, microwave cases with bad outcome is 2 out of many cases. So this is just trying to show his failure cases. There are a lot more successful cases actually. So our group and Rosella from Rosella Nicoletti from Italy actually wrote a review 2 years ago on the retreatment rate and the salvage treatment rate. It's highly variable. I think the message is not very clear. It's like the answer is highly variable between centers in the same energy. So I think in the end, yeah, and actually redo focal ablation is feasible. And salvage prostatectomy is technically feasible. It's more difficult, but it's technically feasible after 1 to 2 focal treatments. I need to rush through. Continence after focal therapy in general, it's actually excellent. So this paper shows that it's 98% zero-pad continence after HIFU. This is Professor Soji's data. Urine incontinence, continence is actually 0%. Focal cryotherapy, complications and continence is also excellent. ED, there will be a proportion of patient having worsened erection and whatever HIFU, cryo, whatever you do, particularly if it is close to the neurovascular bundle. This study from in UK shows that the sexual function actually recovers beyond 6 months to 9 months, so most likely will go back to the baseline. And this is a microwave data showing, this is a Frenchman. I couldn't show that in my Chinese cohort because most of them had a pretty bad sexual function from the start, or they are actually not sexually active in those 60-something-year-old men, which is common in Asia. But this is a French cohort, which shows that, the IIEF5 was preserved at 1 year. And most of the pad-free rate across different focal therapies are actually more than 92, 93%, some some of them actually between 20, 30% would actually have some deterioration in erectile function. Now, I would like to draw attention to this, like post-prostatectomy continence, when robotic surgeons, including me myself, like quote to the patient that like you have like long-term incontinence rate of like 10%. Now, 10% is something like 2 or more pads per day. But in fact, when you talk about zero-pad continence, it's actually much more than 10%, okay? And it also increased with age too. So if you're looking at 72, 75-year-old man, if you do a prostatectomy, then you're expecting like the rate of continence is much higher. So any leakage rate in this study is between 35 to 52%. Now, you might argue that 1 pad is okay. So to a surgeon, it's okay. To a patient, I'm not so sure. And I learned that recently. More and more patients tell me that. I ask the patient, how's your urinary control? I said, it's okay, 1 pad per day. So this is within that 90% that we say this is okay after prostatectomy. But then the next sentence is, it's 2 pads or more if I go running or hiking. So is it 1 pad? Like 1 pad if you sit at home, okay? So my take is the social continence is not good enough, and any continence actually may limit the activity of the men after prostatectomy. So this is somewhat, this is not being stressed by most robotic surgeons. And if you're beyond 70 years old, the failure-free survival is like 82% at 5 years. And I more and more think that like the focal ablations, energy ablations of the prostate is actually excellent for those that are beyond 70 years old, because even they have like 10 to 15 years of life expectancy, they probably will need no more treatment, or maybe 1 more repeat ablation of prostate, and they can actually avoid radical treatment for the rest of his life. So the conclusion is that focal therapy preserves continence and normal activity compared with prostatectomy and sexual function. MRI visible lesions in one region of prostate would be a good candidate, and if in well-selected cases, inexperienced hands, not experienced as Professor Amberton or Professor Shoji, but still you can get like a 15 to 20% radical treatment-free rate between 5 to 8 years, so it's probably okay. But in the end, appropriate case selection and your experience in using the NG is very important. So this is a team in CUHK Urology in Hong Kong. Thank you very much.
Yeah. Thank you very much, Dr. Peter Chiu, for your excellent talk. With the time limit, we just open one question. Yeah, Emerton. Thank you.
Peter, thanks. So I think your the first part of your talk, where you look at the series, and one thing you didn't say, which I think strikes me increasingly, is that the old series were done include whole gland, pre-MRI, pre-PSMA PET, pre-fusion biopsies. The majority of patients were treated in a kind of previous era without the precision. And I think if you look at the very recent series, the majority of patients with MRI, with PSMA PET, with fusion. And so practice, the standard of care has changed a lot, which is why we're seeing improved outcomes in the kind of contemporary series, the ones that have been around, that look at patients in the last 3 years. And of course, they don't include many learning curves either. So I think, it's very interesting to see the old series because you've got long-term follow-up, but it's becoming less and less relevant because we don't manage patients in that way. So I think I'm quite interested in these short contemporary series that are achieving these much higher kind of cancer disease-free rates, which you'd expect given modern techniques.
Yeah, fully agree, Professor Amberton. But as you mentioned, yes, they have like median follow-up of 2 years, 3 years, and then people judge like, that's a short follow-up. Then we look at the old series, and then that's true. So we probably have better and better results in the years to come. Yeah, and that's also bring us to the importance of putting we are in the UAA in the Asian meeting, the importance of putting the data of different Asian centers together and to look at and also we need to have a benchmark. We need to know, am I doing a good job? Do I need to improve? So I think and these are all very important. Yeah.
Peter, in the sexual dysfunction, we have noticed using the IRE problems with ejaculation, no erection problems, but ejaculation. Somehow the volume is reduced, and sometimes some of them had dry ejaculate. Have you seen this with your microwave series?
I think it happens in any energy.
Yeah.
It depends a few things. So antegrade ejaculation preservation. It depends whether you're ablating near the central zone or the ejaculatory ducts, because I'd actually some patients actually, if the lesion is around that area and you have no choice to ablate adequately in that area, some would have significantly reduced ejaculate. So my take to it, my lesson to learn after a few young patients telling me, doctor, you told me that I will retain my ejaculation. Now I only have a drop each time. So he's not happy. So I think in counseling, it's important to tell, particularly we look at the MRI, look at your plan of treatment. Before that, you tell the patient, what you're expecting. If the tumor is really next to the neovascular bundle, sticking next to that, then, we expect the erectile function to deteriorate a bit, in the long term, even though it's just one side ablation. But at the same time, I actually, if you have a wide range of ablation, like a very good hemigland, and sometimes the shrinkage of the prostate is so much that somehow it's just like debulking prostate, like TURPs. Sometimes you have a bit of retrograde ejaculation too. But to me, I think the ablating the ejaculatory duct may be a more major factor. So I'm no expert in this. So maybe Professor Amberton, do you have any insights in this?
Sphincter, the preprostatic sphincter often gets hit, so you get retrograde ejaculation or emission failure if you hit the duct, but also you change the shape of the prostate and you can create a cavity in the middle which exceeds the volume of ejaculate. So you have an emission but no ejaculate, and then it comes out So I think there are lots of reasons, but it's very hard to predict, and they always forget that you told them that their ejaculation would be less beforehand. It's incredible. Yeah.
Thank you. Very active discussion. Thank you, Dr. Peter Chiu again. And then we'll hand on to the next section.
Good afternoon, ladies and gentlemen. I'm Dr. Xun-Hong Chen. I'm the president of Taiwan Adventist Hospital. Today is my great honor to introduce our next speaker, Dr. Lechmian Landon. He has a very long first and last name. So I know
you
your
for
friend call
noticing.
you Dr. Siva. Yeah. Dr. Siva is now the consultant urologist and the head of urology in Raja Permaisuri Penang Hospital in Malaysia. Yeah. He is a very well-experienced HIFU expert. He ever as an invited speaker in SIU in New Delhi in 2024. So today his topic is beyond oncologic control, the real world experience in HIFU therapy for the prostate disease. Ladies and gentlemen, please give a big hand to welcome Dr. Siva.
Thank you for the kind introduction. What I like about this topic, it truly reflects me, is all based on my personal experience. I'm not an academician, so I'm not going to quote a lot of publications and data. So in Malaysia, we have prostate cancer commonly among those in their 70s, and life expectancy is increasing. So we have patients living longer, and therefore treatment seems to be more delicate for them now at this age, and hence the need for focal therapy. This is just going through some of the data from real-world experience for Malaysian prostate cancer. During the study period, we had 1,839 patients with a median age of 70 years. 50% of them have major comorbids, 50 of them high-risk patients, and 72% presented at advanced stage. We're not picking up cancer cases early enough in Malaysia. And how does this compare to our neighbors not too far, Australia? 33% are diagnosed between 50 to 64 years, 82% present at early stage. And they are able to achieve a 96% 5-year survival rate. And how did they do it? Well, they have effective screening program done at primary healthcare level, adequate resources for imaging, and all forms of treatment modalities. So the key note here is before we even embark on focal therapy, we need to be picking up the disease much earlier. Unfortunately, in Asian countries, we are sort of backward that way. We need to empower healthcare, primary healthcare people to sort of start that up. So just pulling out data from the Malaysian population, I just want to highlight that at stage 1 and 2, we're probably over-treating patients with radical prostatectomy and radiotherapy because there's no focal therapy option available. And you're possibly under-treating about 31% of them because most of them put on active surveillance because of the age factor and comorbids. So it's a bit of a concern. So a possible quarter of this group of patients could have potentially benefited from focal therapy. There's one slide I keep repeating in every conference is this. Patients should be made aware that there is a potential role for focal therapy, which is in between active surveillance and surgery or radiation. And what's the evidence? Just simply put, in the EU guidelines, it is strong, and you can offer focal therapy, HIFU, cryo, as long as you're conducting within clinical trial or registry. So just to move on, this is a paper called the HIFI trial, which prospectively compared HIFU versus radical prostatectomy, the first of its kind. And mind you, while the results show that the salvage rates are similar, the group selected for this study were intermediate risk. And at 12 months, continence was better in the HIFU group. So it is pretty clear-cut that focal therapy gives you that advantage when compared to radical prostatectomy. So I'll skip this HIFU over video, and we've gone through how focal therapy can be done whichever pattern you like. And what I like about the system with HIFU is that you get live visualized changes. Some call it the popcorn effect, some call it the Uchida effect, but you see ablation with cavitation immediately during your treatment. And so you can even do fusion HIFU, which is close to urethra. I had this patient, one of my first 4 cases, and what you can see there is actually that's the catheter running through, and the tumor is actually on the urethra. So how did we go about it? We did ablate the whole area. 2 weeks later, I went in to have a look if this patient was going to develop stricture. The video on the left is the cystoscopy after 2 weeks. You can see some black marks with a bit of char. It's sort of narrowing. And the video on the right shows that using the button, doing a TURP, it is actually quite feasible, easy to do. You will see a lot of these charring changes. The tissue is not going to gelatinously drop and fall off completely. So you get kind of a stiff tissue, easy to resect, and as you can see, hardly any bleeding. So that's one of the options of treating these patients, especially if you've got someone going for a whole gland, who will definitely end up with catheter prolonged time. So anyway, moving on, if you're starting up your own focal therapy program, HIFU, in your country where it's not been approved, it's best to go through the right channels. So I wrote into the Ministry of Health in Malaysia to get approval for focal therapy with HIFU. And we had a meeting with the head of urology and the head of oncology. We have a division called the Health Technology Assessment Group in Malaysia who goes through the guidelines and whatever evidence available. And therefore in Malaysia, then they came up with a recommendation that you can perform focal therapy with HIFU as long as they're up to T2 intermediate risk in a designated center by a trained urologist, as long as you maintain a registry. So I went on to start the Malaysian registry, and we're now collecting data to keep it all real. So we've gone through, the earlier speakers have mentioned, Dr. Vincent, got this Falcon consensus on who you should offer focal therapy and who you shouldn't. So it gives you a good guide for someone who's starting off new on patient selection. So mainly visible focal lesions. And well, I'm not too rigid about the fact that if it's anterior, it has to be needle-based, and if it's posterior, it has to be wave-based. In my experience, if you know your energy well, it can be used for both anterior and posterior lesions. So as long as you know the limitation of the energy you're using. If it's HIFU, it has to be within 4 centimeter AP height. If you're doing needle-based, try and stay away from the sphincters. So as long as you know the type of energy you're using, you can. There are ways to go about this. And yeah. So again, those are the consensus. So this is my personal data. I've done about 83 cases now. And as you can see, this is real world data. There's nothing hidden here. Most of my patients come with quite high PSA levels, some of them as high as 26 or 24. But these patients who come with such high PSAs, all of them get PSMA PET scans. And on a PSMA PET scan, they've noted to have no metastatic lesions, all confined within the gland. And another interesting thing is that in the Malaysian demographic, the prostate sizes average between 50 to 60, some of them on my series. So it's a bit difficult to try and treat all of them based on the European papers where prostate glands are only 20, 30 grams. So I've done a series now. We've got 20 patients who've reached the 18-month mark. 5 cases have done a whole gland, primary HIFU, and the PSA response has been quite good, I must say. And about 15 cases now who've had hemigland or a hockey stick ablation. And you can see that, of course, the PSA drop isn't significant as compared to whole gland. They sort of plateau. But the good thing is they plateau on and stay on if there's treatment success. Now, I have had patients with progression after HIFU. And this is where I wanted to highlight how the PSMA is like a double-edged sword. So this one patient I had with a PSA rise after 3 months, whom we thought was a failure. He had a hemigland ablation based on a truss biopsy done by someone else. And this is where I agree with Dr. Vincent that you should do your own biopsies if you're offering focal therapy. Now, he had an infill recurrence based on a PSMA PET. And interestingly, it showed that the seminal vesicle on the opposite side was also positive on the PET scan. So the patient opted to go for robotic prostatectomy. But when the HP came back, the seminal vesicles were clear. It was negative. And the tumor volume was just 3+4 within the same gland. So a PSMA has now caused a shift in management. This patient could have gone for a second HIFU, but because the PSMA PET showed something else, management completely shifted. So we have to take the results of PSMA with caution as well. Another patient was a poor selection. I tried to save money for this guy and didn't repeat his MRI. I used an MRI which was 7 to 8 months earlier, which showed it was 48 grams. But on table, when I measured, it was 70 grams. And the tumor mid was just about hitting the limit for a HIFU, which was 4 centimeters. So we managed to burn. He, of course, developed recurrence, infield as well as outfield progression. He's had a second HIFU and the PSA has come down. So don't think that just with one treatment it's failure. As the guidelines have said, it's two treatments minimum. So these are my real-world experience complication rates. I had one patient with the early urethral stricture, a guy whom I performed a whole gland HIFU, who refused TURP post HIFU, and he was on self-catheterization for 6 weeks. Interestingly, it spontaneously resolved. He was able to pee after that. And these series of UTIs and epidermal myocarditis also occurred in those with whole gland treatment. Whole gland, of course, creates more coagulative necrosis, so they are at higher risk of infection, but generally they do well with the course antibiotics. For the rest of these patients, I maintain 100% continence, 100% maintenance erectile function, and thankfully no rectal fistulas. So what about salvage HIFU? Now, there's a lack of robust data on randomized trials comparing different glands, but it has been on the NCCN guidelines that it's safe energy to be used with good overall 5-year survival rates. With my limited experience with HIFU, I only had one encounter, and it happened to be that I was invited to proctor a case in Tata Memorial Hospital. So a 68-year-old gentleman who had undergone an SBRT after already undergoing a radiotherapy to the whole gland. And so he had biochemical recurrence. As you can see, the PSA trend there. From 0.09, it's gone up 0.53, 1.7, 2.94. So had a PSMA PET. You can see a focal lesion. And this is the MRI on the T2 sequence and also DWI and ADC. It's all there. So this patient had a biopsy done, and it showed to have a 4+4, Gleason 4+4, grade group 4. Well, because they ran out of options, they thought HIFU would be a good option. Wasn't a great option as their first case, but so I land in Mumbai, being told that this was actually a simple case of HIFU on the left posterior apex, only to find out on that day it was a salvage. So alarm bells were ringing. I contact Dave Keegley, and that's a brilliant part of Sonablate HIFU. The support that you get is immense. Contactable at all times. They have a support team on 24/7, and you can discuss cases with them. They give you feedback. There's a live Sonalink, which can monitor your system as well. So anyway, we planned for a 2-zone quadrant ablation, and we gave low energy settings. Image was not very clear. This is the problem with salvage cases. There's a lot of hypoechoic changes on the periprostatic fat. In this video, if it plays, yeah, I'm not sure why it's not playing. As you can see there, this is despite lowering the DGC. DGC is a component called the depth gain control, where you can reduce the brightness. And despite reducing the brightness, it was still hyperechoic. Nonetheless, we gave low energy repeatedly. I did a double tap, so it took a longer time, where we allowed the prostate to cool down. After 5 minutes, we went again, low energy, and did another round of ablation. So in short, after 3 months, the PSA dropped significantly from 2.94 to 0.045. Thankfully, no irritative symptoms and no rectal fistula. Not sure how the patient is now. Hopefully, Prof. Mark Emerton can update me once he goes to Mumbai. And just a quick one on BPH. So this is another indication of using HIFU which has just come up. And generally for patients with a prostate volume less than 80 mils, how it's performed, there's a pattern called the checkerboard pattern, where you burn one and skip one. Otherwise, it's all the same. You focus on the transition zone and periurethral tissue especially, and that's how a checkerboard looks like. It reduces the ablation time by half because you're only doing half of that. I don't have any personal experience with this, so I'm sharing these slides from colleague Dr. Xin Wang from Fushan, who presented this in Tianjin this year. 262 cases of BPH prospectively collected data. Average treatment was actually 39 minutes. Catheterization time was 3 to 9 days. And he followed up these patients for 3 years. So interestingly, as you can see, the prostate volume did not significantly drop, right? But what is interesting is that this prostate volume actually maintained in that sense for 3 years. Now, most of the other minimally invasive treatment options, the prostate volume tends to creep up as the years go by. I'm not going to name them. And interestingly, the IPSS score had a significant drop, and that too maintained very well in 3 years. The Qmax of the patient picked up significantly, and that too maintained. So what I like about this data is the sustenance of its effect over the 3-year period. So for at least 3 years, it's pretty safe. So it's got good safety features. Significantly avoids complications such as sexual dysfunction, strictures, bladder neck, as we know. Effectiveness, the clinical effect gradually improves after HIFU. Absorption of necrotic tissue requires a certain amount of time. So you have to counsel your patients that they have to be patient with irritative symptoms in the first month. In conclusion, no significant damage to surrounding tissues, no significant physiological biochemical changes you see with TURP, and it's suitable for the elderly patients with multiple comorbids, particularly on patients who are on anticoagulation, because you can continue HIFU with anticoagulations on. So naturally, that's a significant added benefit. So in conclusion, take-home message from my real-world experience, it is a safe procedure with low-grade complication, good preservation of urinary and erectile function, and good cancer control in the short and intermediate term. Active surveillance is still necessary. Some patients will require repeat HIFU. They can still go on for radical treatment. And focal HIFU could be a standard care for well-established patients, well-selected patients, or radio recurrent prostate CA. Still awaiting results of high-quality competitive trials. And treatment outcomes for well-selected BPH cases are quite encouraging. Again, waiting more data. With that, I'd like to thank you.
Thank you, Dr. Siva, for your great talk. Because I know there's a panel discussion later, so I would like to move to the next moderator, Professor Chen.
Today is my honor to introduce this session speaker, Dr. Xie. Dr. Xie now is the assistant professor of China Medical University in Taichung. He's very experienced of MRI prostate fusion biopsy and very familiar with the focal therapy of the HIFU. Now, he will give us a very challenging topic, how to follow up patient or follow up the PSA after focal therapy with HIFU. This is very challenging to all the doctors, how to follow the patient, because some of the patients don't have ablation or focal ablation. So how to communication with the patient when the PSA elevated, how to follow patient is very challenging. Now, Dr. Xie, please.
Thank you. Hello, everyone. I'm Dr. Xie from Taiwan. Today, my topic is follow-up after HIFU. And this is a focal therapy society statement. It says that after HIFU, we should check the serum PSA every 3 months, and we should arrange MRI on the 6 and 18 months after HIFU, and we should do a routine follow-up biopsy between the 6 and 12 months after HIFU. And besides, we have to use the IPSS or IIEF to check the urinary and sexual function. So today my talk will focus on PSA, image, and follow-up biopsy. So let's start with PSA. And this paper talk about the role of PSA density. 73 men underwent focal HIFU, and after 1 year, they arranged MRI and a routine follow-up biopsy. And overall, 33 men had a negative MRI. And if we divide them by the biopsy data, we can see that men with the Gleason score 7 or higher would have a higher PSA density, about 0.16 versus 0.07. And this paper assessed the role of percentage PSA reduction. 700 men underwent focal HIFU, and then the median PSA decreased by 73%, and the median time to PSA nadir was 5 months. And for men who had PSA decrease over 90%, only 20% of men may need additional treatment within 5 years. However, for men who had PSA decline less than 10%, up to 70% of men may need additional treatment. And nowadays, most doctors would like to use a specific increase over the PSA nadir or the BCR to define the treatment failure. However, we should keep in mind that since we did not remove the whole gland, we cannot use the BCR for RP. And this paper showed that many studies use the PSA nadir plus 2 to define the BCR after focal therapy. However, according to the latest focal consensus, there is still no consensus on PSA failure definition after focal therapy. And in 2020, Dr. Huber proposed that we may use the PSA nadir plus 1 within 1 year or PSA nadir plus 1.5 within 2 or 3 years to define the BCR after HIFU. It can achieve an NPV between 96% to 100%. And this is an external validation study. It shows that using the Huber criteria was better than the PSA nadir, time to PSA nadir, or PSA reduction to estimate the treatment failure after HIFU. So the Huber may serve as a standardized approach in the follow-up after HIFU. And the second topic is imaging. And we always arrange MRI to assess the treatment effect after HIFU. However, within 3 months after HIFU, there may be some tissue edema, necrosis, inflammation, or bleeding. So in order to decrease some artifacts, we should arrange MRI at the 6 months after HIFU. And this paper compared the role of PSA parameter and MRI in the follow-up after HIFU. And it showed that a late MRI had a better area under curve than the early MRI PSA nadir or PSA density. The NPV was between 86% to 97%. And this meta-analysis evaluates the role of MRI after HIFU. It showed that MRI had a poor sensitivity of 81% and a poor specificity of 91%, and the area under curve was up to 0.81. However, if we look at studies with 50 men or higher, the sensitivity was down to 0.68 and the specificity was down to 0.75. And nowadays, we often use the PIRAS to read MRI. However, we should keep in mind that PIRAS was initially established for the biopsy-naive men, not for men who underwent focal therapy. So for this issue, the UCL group has proposed a PIFAB score, and it assesses the DCE, DWI, and T2 weighted image. And it also compared the pre-treatment and post-treatment MRI, and then 3 scores were assigned. For score 1, we can keep observation. For score 2, we have to correlate with PSA kinetics. And for score 3, we should go on the prostate biopsy. And another score is the target score, and it assesses the risk of cancer on a scale from 1 to 5. And this paper compared the PIFAB score and target score. It shows that PIFAB score may have a higher sensitivity and target score might have a higher specificity. phase T. Besides, both of the two scores has a high inter-reader agreement. So these two scores seems promising, and we need more data to approve their efficacy. And another image tool is Pismapet. This study showed that the SUV max, SUV ratio, and primary score were associated with treatment failure after HIFU. However, until now, the studies of the PSMA PET was only a few, and the data was a little bit controversial. So we do need more data to approve the efficacy of the PSMA PET. And the third topic is follow-up biopsy. And this review paper showed that after focal HIFU, about 5 to 22% of men may have in-field recurrence, and about 12 to 29% of men may have an out-of-field recurrence. So we have to do a target biopsy of the ablation zone to detect the in-field, and we have to do a systematic biopsy of the non-ablating zone. And for the timing of biopsy, basically, we have two options. The first one is a for-cause biopsy, which means that we can do biopsy only if PCR or a suspicious finding on MRI. And the second one is for protocol, which means that we always have to do a biopsy at a predefined time, no matter what the PSA level or the MRI. And some studies have shown that within 3 years after focal therapy, a for-cause biopsy and a for protocol has the same tumor-free survival. And we have to keep in mind that a for-cause biopsy should only be done in men with extensive experience of focal therapy. And on this issue, we also published our experience. And this paper was based on Shoji's cohort. And after HIFU, we checked PSA, and half a year, we also arranged MRI, and we did a follow-up biopsy. And on the RC curve analysis, we found that if we combine the percentage PSA reduction and NPMRI, we could achieve the best area under curve up to 0.982. And if we use the PSA decrease less than 70% to determine the biopsy candidate, we will miss 12% of CSPC. And if we use the MRI 3 or higher to determine the biopsy candidate, we still missed one case of CSPC. And if we combine the PSA and MRI, and nobody of CSPC was missed, and we could avoid more than half of the biopsy. So for men who had a PSA decline over 70% and no suspicious finding on MRI, maybe we could avoid routine follow-up biopsy. So in conclusion, after focal HIFU, in order to early detect the cancer, we should include periodic PSA, MRI, and follow-up biopsy in our surveillance protocol. Thank you.
Thank you very much for Dr. Xie's excellent speech. Any question from the board? Okay, thank you.
I would just like your advice on this, actually, or anyone. In the real world setting, most patients are PSA driven. So if the PSA remains low, despite treatment after 1 year follow-up, most of them are not very keen to get a repeat MRI and then to be rebiopsied, because it adds cost. In most of countries, Southeast Asian countries especially, not everyone is reimbursed. So what is your experience if you don't do an MRI and biopsy at the end of 1 year and only do them when the PSA starts going up?
Well, my principle is to always arrange a MRI, and we follow PSA. And I would always suggest a biopsy, but about 10 to 20% of men would refuse it.
Okay.
So the MRI, to do the MRI is dependent on the PSA adoration or routine?
No, I half a year after HIFU, I always arrange MRI.
Okay. So routine?
Routinely.
Okay.
Yes.
Can you consider the P-HIFU PSA level and the volume of the prostate? Or all the patients with the PSA reduction over than 70% is a critical point, or any other parameter can be considered according to the patient's condition?
Actually, I think the percentage PSA reduction depends on how much volume you have ablated. If you ablated only a very small area, the PSA will drop not so much.
If the patient's the posterior volume is very big before HIFU, 80 over there 80 gram, and we do focal or hemi HIFU for this patient, because another part of the prostate, the volume is still very large. So maybe the PSA reduction not over than 70% is, I think this is maybe constant in this kind of patient.
Yes.
Or routine, if the patient's not reduction over than 70%, MRI is routine critical practice in this kind of patient.
Yes, because of the various PSA reduction, I always have to arrange a MRI. Yeah, so we cannot. Please.
Okay, thank you.
Many studies related to PHI, which is 5. And I'm wondering that, have you ever studied the changes in PHI before and after focal therapy? And do you think there's PHI has a role after the focal therapy? Yeah.
Well,
to see the especially the Pro2 PSA reduction, because it is more specific to the prostate cancer. And I also want to ask the Dr. Peter and Dr. Shea's.
Okay, I have no experience of the PHI in the follow-up after HIFU.
Okay.
And maybe Peter.
Thank you, Sean, for the question. We actually, as a prospective protocol, we actually collected the pre and post focal therapy prostate health index that includes the P2PSA too. Because the numbers are quite small, so it's almost around 100. So we want to collect more before we can actually look at it. But just by eyeballing on my impression, the P2PSA level is actually quite sensitive, and so the drop in the percentage of the P2PSA is actually more than that from the PSA, of the total PSA. Yeah. So I think it will be useful, but how useful it is in the presence of like MRI that you would do, follow up, and of course, in addition to PSA, and so I have no answer to that yet. But I think Dr. Xie actually published a nice paper showing the suitability of the focal therapy based on not only PSA but the prostate health index. The higher the prostate health index by the radical prostatectomy final specimen, the area of the prostate, the volume of the prostate cancer is actually more than the degree of the under represented tumor on the MRI is more if you have a higher prostate health index, which means if you have a high prostate health index, you're even more underestimating the tumor extent on the MRI. So the conclusion is, if you have very high PHI, maybe you should have a bigger margin during your ablation. Yeah.
Thank you.
Thank you.
So I think many questions may be considered in our critical practice. Maybe the next session, the panel discussion, we have a much specialists can discuss this program. Okay, thank you.